Hello, good evening, everybody. We're gonna just give a couple minutes as folks are joining us, but excited to have you here for our annual general surgery review website prep session. And we'll just give another minute or two, and then we will go ahead and get started. All right. Well, let's go ahead and dive in. So good evening, everybody, and welcome to our annual SAGES General Surgery Review, Part 1. I am Michael Awad, minimally invasive surgeon at Washington University in St. Louis, Missouri. And along with my co-panelists, Dr. Amber Traugott, Dr. Jeff Blatnick, and joining us in a bit will be Dr. Tim Vreeland. We're very excited to host you here again for what is often very popular and successful session. Our session is jam-packed, so we're going to go ahead and dive in here shortly. Just a couple of notes. The session will involve a live Q&A, so that will pop up as a feature on your Zoom screens there. We will be monitoring that, and we will do our best to try to answer as many questions as we can, either verbally or by text. The chat itself will be disabled, but you will be able to use the Q&A. This session is also recorded, and after a few weeks will be available on the SAGES website for you to review as you'd like prior to the app site. All right, so let's go ahead and dive right in. I'm going to bring up my screen here, and good. Jeff and Amber, you can see that okay? All right, yep. Great. So just an outline of our session this evening, we're going to start out with just a bit of an overview, and then we will dive into our four main topics for part one, as you can see here, presented by each of the panelists. I do want to bring up a quick note about SAGES. SAGES is the Society for American Gastrointestinal Endoscopic Surgeons, and it is the society that is obviously hosting this popular webinar every year. We'd encourage you, if you are not already, to consider becoming a SAGES member. I've been a SAGES member since 2003, and it has been a phenomenal society to call home. That has helped me with both my professional and personal development. SAGE's vision is to reimagine surgical care for a healthier world, and its mission is to innovate, educate, and collaborate to improve patient care. And the values are the following: inclusivity, innovation, service, excellence, global community, and of course, fun. Things that you can benefit as a member include a significant discount to the SAGES annual meeting, and we'll talk about the exciting location where SAGES is going to be this coming spring in just a minute. There are amazing educational programs, both like you're seeing here tonight, the webinars, in-person hands-on courses. SAGES sponsors robotic courses, laparoscopic, endoscopic courses, all for residents and fellows alike. A huge network through which you can communicate and for professional development. You get a free subscription to the journal, Surgical Endoscopy, and things that only members can get, such as research grants, career development awards, and others. So been a phenomenal organization, and would strongly encourage you to apply. The fee for candidates, resident members, is a very modest nominal fee, and it's a very easy thing then to roll over to become an active member once you graduate residency. This coming spring, SAGES will be in Montreal, Canada. I'm really excited about this, and Montreal is beautiful around that time of year. Really looking forward to seeing everybody again in person and I saw the preview of the program. It looks like another phenomenal meeting, again, with plenty of sessions for residents and fellows alike. Just a note about the content that we cover. So this is a list from the app site the American Board of Surgery in-service training exam. And you can see here a range of topics that are included on the website every year, as long as it's weight. This session, we're going to cover the topics that you see listed here. And then in part 2, we're going to cover much of the following topics that you see on the bottom part. So we do cover a significant chunk of the topics that are covered on the website. By popular demand, we moved to 2 sessions a few years ago, just to make sure we can increase the breadth of topics that the session has. So again, just a note about the format. We try to make this engaging, and so it will be multiple choice. We're going to read a stem, and then the question responses will be on your screen. You will have the Zoom polling feature come up. So whether you're on your smartphone or your desktop, you can answer through the Zoom polls. And then we'll close the poll. We'll talk about the correct response, as well as maybe some of the incorrect responses and why those are the way they are. As I mentioned, we will have the Q&A open that you can put your questions in, and we will do our best to try to answer them as possible. All right, so without further ado, I will kick us off. So again, I'm a minimally invasive surgeon at Washington University in St. Louis. My practice specializes in benign foregut surgery, hiatal hernias, reflux, achalasia, and so forth. And we'll kick off with the esophagus, stomach, and obesity topics. So our first question. A 3-year-old is brought to the emergency department with chief complaint of refusing to eat for 12 hours. There's excessive drooling on exam. The abdomen is soft and non-tender. Breath sounds are clear. A chest X-ray shows a large cylindrical foreign body in the upper esophagus. What is the next best step in management? A, observation with serial chest radiographs. B, upper endoscopy. C, thoracoscopy. D, barium esophagram. Or E, CT scan of the chest with contrast. All right, we'll give just another second there, and then we will close the poll. Okay, so the correct answer is indeed B. Looks like most of you got that. So this is a little kind of warm-up question to kick us off. Again, the diagnosis here is pretty clear. The X-ray shows the foreign body, so there's not really a need for any further imaging or certainly observation. Really, upper endoscopy is going to be the next best step here, especially as the patient has drooling. So there's a suggestion of not being able to manage their own secretion. So yeah, upper endoscopy is the correct answer to deal with the foreign body. All right, and we're going to reset the poll here. Our next question is, a 29-year-old female seeing her primary care physician after a recent heroin overdose. She has hypertension controlled with enalapril, diabetes mellitus controlled with oral hypoglycemic. She has a 2-centimeter hiatal hernia and GERD controlled with a daily PPI. Her BMI is 38. She has used heroin to deal with her self-image. She has tried non-surgical weight reduction programs without success. Which of the following would exclude her from consideration from bariatric surgery at this time? A, that her BMI is less than 40. B, 2-centimeter hiatal hernia. D, diabetes controlled with oral hypoglycemics. D, hypertension that's controlled with enalapril. Or E, recent heroin overdose. All right, we're going to close the poll. And indeed, the correct answer is E. This one, again, pretty straightforward. There was a couple of responses in some other categories. This is just a good time to review a little bit about the indications for bariatric surgery. I will say this is a very common question that comes up on the app site. So it's just important to kind of review or talk about that. At least in different countries, it varies, but in the United States, typically to get insurance approval for bariatric surgery, the indications are a BMI of 40 or more, or a BMI of 35 or more with comorbidities associated with the disease of obesity, such as diabetes, GERD, hypertension, arthritis, and others. So while this patient's BMI is indeed less than 40, there are comorbidities here as well that could benefit. Certainly the hiatal hernia is not a contraindication and would be repaired at the same time. And although the diabetes and blood pressure are controlled with medicines, that does not mean they're medically refractory. It's still an indication for surgery. And of course, the issues with the active illicit substance use is going to be the major contraindication here. All right. A 50-year-old man has previously undergone intractectomy, vagotomy, and Billroth 2 reconstruction for intractable pain due to a duodenal ulcer 6 months ago. He was seen in your office 2 weeks ago with complaints of epigastric pain, nausea, palpitations, and anxiety 2 hours after finishing a meal. Diet modification was recommended, but now your patient returns with no amelioration of these symptoms. Which of the following has been shown to successfully treat this condition? A, proton pump inhibitors, B, H2 blockers, C, somatostatin analog, D, cholestyramine, or E, sucralfate. Good. Of course, you have to kind of know what disease condition they're talking about here, or what complication perhaps of a Billroth 2 reconstruction. All right, I'm going to close the poll, and the correct answer is indeed C. Just a quick review. This is the anatomy of a Billroth 1 and a Billroth 2 anastomoses. This patient is described as having a Billroth 2, and the condition being described as dumping syndrome. So the treatments are focused around that. This is kind of a way to think about the pathophysiology as well as treatment algorithm. So, basically with the reduced gastric volume or the gastroenterostomy, you're having rapid delivery of nutrients into the duodenum, which then stimulates this kind of hyperosmolar contents and this kind of so-called early dumping syndrome. That's where those somatostatin analogs are really acting to treat those vasoactive agents that are causing the dumping syndrome. There are some diet changes that can be recommended as well, but this is really kind of the focus for this question. Next one. A 32-year-old woman presents to the emergency department with mild upper abdominal pain 5 days after routine laparoscopic Roux-en-Y gastric bypass. She's been anxious and had chills. She's tolerating a postoperative diet, has mild pain when she eats. In the emergency department, her temperature is 37.8, blood pressure is 110/80, heart rate is 120, and respirations are 18. The white blood cell count is 12,000, and all other labs are normal. What is the most likely diagnosis? A, atelectasis, B, anastomotic leak, C, aspiration pneumonia, D, pulmonary embolism, or E, urinary tract infection. All right, we're going to close this poll. And the correct answer is B, anastomotic leak. This too is a very common question, not only the ABSITE, but also on the oral board examinations. And so the teaching points here are patients who are postoperative from a gastric bypass can have any of these complications, frankly. And you have to have a really low suspicion for working them up. This patient here looks fairly non-toxic, really just some anxiety, some tachycardia, but otherwise pretty unremarkable. 5 days, though, after laparoscopic gastric bypass, there is a little bit of leukocytosis that's not normal, as well as the tachycardia, that too is not normal. So an anastomotic leak must be evaluated for and ruled out. Some of you indicated PE, pulmonary embolism, certainly also very important condition to rule out. Regardless, this patient is going to get a CT scan, but there's no indication of shortness of breath or chest pain here. A 44-year-old construction worker is referred to you with symptoms of difficulty swallowing solids and liquids and a sensation of food sticking at the xiphoid. He has lost 3 pounds over the last 3 weeks unintentionally. His BMI is 27.5. He smokes 1 pack of cigarettes per day. The physical exam is normal, except for a small epigastric hernia. The next step in management should be A, contrast esophagram, B, upper GI endoscopy, C, esophageal manometry, D, 24-hour pH monitoring, or E, proton pump inhibitors. We'll give another couple of seconds for this one. All right, good. I think we're going to have to talk about this one a little bit. So the correct answer is A, contrast esophagram. Most people answered either A or B. So let's talk about this a little bit. And I will say, on your boards, you will not be faulted for doing an upper GI endoscopy. However, it's a little bit of just kind of a timing of sequence and appropriateness of studies. There are a number of people who believe that the very first step in evaluation of a patient with dysphagia, this is the patient's primary symptom, is dysphagia, should be a contrast esophagram. And the reason for that is to evaluate for any strictures or things like esophageal diverticula, that if you are not aware of them beforehand and you do an upper endoscopy, you could create a perforation. This is especially true for esophageal diverticula, in that the diverticulum the diverticular lumen is often bigger than the true lumen of the esophagus. And if you're not aware of it, it's a risk factor for perforation. So there's the leaning for the contrast esophagram. Again, if you said upper GI endoscopy on your boards, you would not be faulted. But in this scenario, the correct answer is esophagram. The other things, esophageal manometry it certainly can be an excellent study for working up dysphagia, primarily motility disorders of the esophagus. However, it's not your best first step. It is an uncomfortable test and done in specialized centers. 24-hour pH monitoring also is more working up for GERD, and that's not our primary diagnosis here. And proton pump inhibitors also is medical management for presumed GERD, which is not what we're thinking here. All right, our next one is a 78-year-old woman in the MICU, medical ICU, recovering from severe sepsis, following a stroke that was complicated by aspiration pneumonia 1 week ago. She has a history of cirrhosis, is still intubated in the ICU, and a tracheostomy and PEG is planned. Vitals are stable. There was a fever last night. BMI is 30. The abdomen is distended with fluid wave. The labs are, you see there, white count of 15, anemic with a hemoglobin of 7, INR is slightly elevated at 1.4. CT scan shows a 2-centimeter hiatal hernia, moderate ascites. Which of the following is the most significant contraindication for performance of a PEG? A, ascites, B, fever, C, leukocytosis, D, hiatal hernia, and E, BMI of 30. All right, good. We'll go ahead and close this one. So most of you got this. The correct answer is indeed A, ascites, although we do have some spectrum of other responses there. So the ascites is going to be significantly problematic for this patient because it will, one, prevent transillumination, which is a critical step in the safe performance of a PEG. Two, it will not allow for a safe tract to form between the stomach wall and the abdominal wall, which can significantly increase the risk for leak. You may contaminate the ascites and result in bacterial peritonitis. So yeah, uncontrolled ascites in a PEG is a big no-no. The other thing that's not on the list here, that's not a contraindication, but significantly a warning, is upper abdominal surgery. So if they've had adhesions in their upper abdomen, it may result in other organs such as the transverse colon or splenic flexure of the colon being near your area and of the PEG, and may increase the risk of a bowel injury. None of the other answers here are contraindications. All right, our next one is a 65-year-old diabetic female with undergoes an antrectomy and truncovagotomy with Billroth 2 reconstruction. We talked about Billroth 2 already. For gastric outlet obstruction due to peptic ulcer disease. She's had postprandial nausea with the ability to tolerate food for 12 months and lost 10% of her body weight. She's been on prokinetic agents without benefit. Her blood glucose has been under good control. What is the best management? A, continued medical management. B, near total gastrectomy with Roux-en-Y gastrojejunectomy. C, conversion of the Billroth 2 to a Roux-en-Y gastrojejunectomy without further gastric resection. Or D, insertion of gastric neurostimulator, and E, hospice care. This is a good one. We'll talk about this in a little bit of depth here. I'll just give another couple of seconds, and we'll go ahead and close the poll. So again, the question is, what is the best management? Here we have the correct answer is B, near total gastrectomy with Roux-en-Y gastrojejunectomy. It does require a little bit of understanding of what is the underlying diagnosis that's being discussed here. The kind of hint is the prokinetic agents. This patient is experiencing gastroparesis. So they've had an antrectomy and vagotomy. So the vagotomy is also a hint there. And she's got nausea, she's had weight loss, and so symptoms that go along with the gastroparesis. They've tried medical management with prokinetic agents without benefit. So the question then is, how do you manage this? Medical management, it's trying to imply that they have kind of maxed out on that. The prokinetics have been without benefit. So that's not going to be an option. Basically, they're talking now about converting to a Roux-en-Y gastrojejunectomy with or without removing the remnant stomach. There are many who believe that if you leave the remnant stomach behind, patients can still have symptoms of gastroparesis even though food is not going through it. They can have kind of persistent pain symptoms. And so actually in my practice as well, if a patient is refractory to other management for gastroparesis, I too will do a Roux-en-Y gastrojejunostomy and removing the remnant stomach in distinction to option C. A gastric neurostimulator is another excellent option from a surgery side for patients who are medically refractory. However, you have to have an antrum. That's where the leads go for this neurostimulator, and this patient's had an enterectomy, so they're not a candidate. And hospice is obviously only indicated for patients not expected to live more than 6 months, which this patient with appropriate treatment would be expected to live. All right, our next question is a 52-year-old female who presents with heartburn and regurgitation. Workup shows a small hiatal hernia, esophagitis, and Barrett's esophagus without dysplasia. Manometry shows some tertiary contractions and is otherwise compatible with the diagnosis of GERD. A recent DEXA scan shows moderate to severe osteoporosis. They did Barrett's ablation. In addition to surveillance endoscopy, what is the best management option? A, daily PPI therapy. B, oral bisphosphonate therapy. C, a toupee fundoplication. D, door fundoplication. E, hilar myotomy. All right, so let's go ahead and close that poll. And the correct answer here is C, toupee fundoplication. So let's talk about this, as there's some variety of answers on this one as well too. Again, this patient is basically having medically refractory reflux is what they're trying to describe here. And they are trying to say that they've already had the kind of workup, so you have the diagnosis. PPI therapy certainly in general is a good initial option, but they're trying to tell you that because the patient has severe osteoporosis, that PPIs have to be used with caution. In fact, with patients with, that is one of the first things known about PPIs, is they can worsen it for patients with osteoporosis. Bisphosphonate therapy is used for treating osteoporosis, but not GERD. Hilar myotomy is used for achalasia, so it's not the correct option. And then what about the two fundoplications? So I put up a picture here just as a quick reminder of our types of fundoplications. We have our posterior full wrap, which is the Nissen. We have our posterior partial wrap, which is the toupee. We have our posterior anterior wrap, which is the door. So if Nissen was on here, Nissen would be a good choice. Toupee is also a good choice. Toupee is a nice anti-reflux procedure that also may have less side effects of gas bloat and postoperative dysphagia than a Nissen. In fact, I've moved to doing almost all toupees now in my practice, regardless of patient's motility. Door fundoplication, however, has not been shown to have, or has been shown to have inferior long-term anti-reflux control. Generally, we don't use it as primary therapy for controlling reflux. The only time I still do a door is in the context of a hilar myotomy to try to just give a little bit of an anti-reflux valve, but it's not by itself a good long-term option for treating reflux. All right, we'll probably do one more question in the stomach and esophagus section, and then we'll move on. A 55-year-old male with a hiatal hernia and gastroesophageal reflux undergoes laparoscopic fundoplication. Postoperatively, he has a satisfactory esophagram and resolution of the symptoms. However, several weeks later, he presents to the office with new onset substernal pain without heartburn or regurgitation. What is the repeat esophagram likely to reveal? A disrupted wrap, B, intrathoracic migration of the fundoplication, C, gastroparesis, D, slippage of the fundoplication onto the stomach, or E, an esophageal perforation. All right, a couple seconds, and all right, we'll go ahead and close out that one. So this also has a variety of answers and some also really reasonable options, but the correct answer here is B, intrathoracic migration of the fundoplication. So let's talk about this a little bit. This one is really trying to get at the mechanisms of fundoplication and hiatal hernia repair failure. And there is kind of a classification scheme that's highlighted in this diagram here. So A, shown in the diagram here, is where the wrap completely comes undone. This is pretty uncommon. This is really a technical failure. It's just, again, it was not done right. The bites weren't big enough. Absorbable suture was used or something like that. That's pretty uncommon. B is showing the part of the stomach herniating above the wrap. C is showing the wrap herniating down instead of up like B is herniating down onto the body of the stomach. And D is showing the whole wrap and GE junction complex moving up into the chest. By far, the most common mechanism of hiatal hernia recurrences is what's shown in the diagram in letter D there, which is intrathoracic migration of the fundoplication. Again, this letter A is pretty uncommon. Letter D is another option, but is also not as common. And this patient is not presenting like somebody with a perforation. He's outpatient in the office without any kind of indication of extremis or perforation. All right, that was a lot of good stuff. We will now go ahead and transition to one of the sections I know that you have all been waiting for. This is a high yield bread and butter section. I'd like to reintroduce and welcome my good friend and colleague, one of my partners, Dr. Jeff Blatnick. Dr. Jeff Blatnick is an abdominal wall core health specialist at Washington University in St. Louis. My next door neighbor in my office. Dr. Blatnick, welcome. Thanks so much for being here and leading us in this next section on general abdomen, hernia, and spleen.
Appreciate it. Thanks for having me. This is such a great thing. I really wish we had something like this back when I was taking the ABSITE. I think this is really, really helpful information. And we'll try to use the next kind of half an hour or so to kind of replicate what Dr. Awad had done, but talk a little bit more about hernias and abdomen and spleen. As was mentioned earlier, if you have questions, put them in the Q&A. We'll try to address them along the way. Hopefully everybody does a good job. So why don't we jump right in for the sake of time. All right, first question for our section. With the dissection of an indirect hernia sactor and an open inguinal hernia repair, you notice an unusual rapid oozing that begins to fill the inguinal canal with bright red blood. The bleeding seems to be coming from the undersurface of the abdominal wall. Which artery is most likely injured? A, inferior epigastric, B, external iliac, C, internal iliac, or D, testicular? I'll give you guys a couple more minutes, a couple more seconds. Good. So great. 84% of you got inferior epigastric. That is correct. When you look at the other choices, external iliac, internal iliac, and testicular, The thing you have to kind of think about in here is that it's coming from the undersurface of the abdominal wall. So when you think about your anatomy, especially if you look at this from a laparoscopic view in the back of your mind, even though you're doing it open, if you imagine kind of how that inferior epigastric runs along the undersurface of the abdominal wall, that's what you're most likely coming to. Certainly an iliac injury would be devastating in a procedure like this. But the most likely thing that you would see would be the inferior epigastric. All right, let's move on to our next question. It's a simple one. You see a patient with an obturator hernia is most likely to present with what? A, dull pain in the lateral thigh, B, hematuria, C, pain on urination, D, sharp pain in the perineum, or E, bowel obstruction. It's a relatively rare hernia, something we just don't see very often, but there are certainly some key things that they present with. All right. So the correct answer here is E, bowel obstruction. So a big mix of people along the way. And so if you actually look at the data for obturator hernias, the most common thing you'll see in upwards of 50% of patients, or even higher in certain studies, is a bowel obstruction is the most common presenting symptom. The other thing you'll see is what's called a Hauschip-Romberg sign. That's usually pain in the anterior medial thigh, not the lateral thigh. And then that's relieved by thigh flexion. So I think the key here to take away is, although dull pain, you can see it's anterior medial thigh is most likely an obturator hernia, not lateral thigh. So the correct answer here would be bowel obstruction. All right, next question. A 45-year-old man comes to your clinic for follow-up 1 month after an open inguinal hernia repair with mesh for an incarcerated left inguinal hernia. He endorses pain along the incision. In addition, the inside of his proximal thigh is numb, burns, or simply hurts when touched. When he moves in a certain way, he gets a stabbing pain in the area accompanied with a sensation of being stung by a bee. Which nerve is most likely causing this constellation of symptoms? So growing pain after open inguinal hernia repair is certainly something we all fear. Unfortunately, it's probably the most common complication we see now that we've kind of moved to mesh-based repair, and recurrences are pretty low. So your answer choices are duplicated here. So A is cremasteric nerve, B, ilioinguinal nerve, C, cremasteric nerve again. That is not trying to encourage you to pick cremasteric nerve. D, iliohypogastric nerve, or E, genital branch of the general femoral nerve. I think the key things here in the stem are where the patient's pain sensation is, and use that to help you make the right choice. All right, let's see how we did. Good. So B is the correct answer. It's ilioinguinal. I think again, the key thing here is that endorses the pain along the incision. That's most likely ilioinguinal. And I think it's pretty safe to say in general, that's the most likely nerve that you would see pain from. Iliohypogastric tends to be more along the midline, if you kind of look at these pictures here, and then genital branch is usually along the medial thigh in isolation. So I think you won't usually see the pain along the incision and stuff if it's strictly a genital branch of the general femoral, whereas with ilioinguinal nerve, you can get primarily that pain along the incision and then can sometimes radiate down into the medial thigh, as was mentioned in the stem. So it's just something you have to remember, but I think taking your time, thinking about the anatomy of where those nerves run is really helpful in getting you to identify these things. And in clinical practice, a lot of times we'll map out where the patient's pains are or pain is in the office to help us get a better understanding of what nerve is actually injured. All right, next question. Testicular atrophy following inguinal herniaplasty is usually due to what? A, thrombosis of the veins in the spermatic cord, B, damage to the external spermatic artery, C, ligation of the vas, D, ligation of the testicular artery, or E, damage to the testicle from mobilization. This is also just one of those questions that we see a lot and you just kind of have to know and remember. So why it's good to get it today, and hopefully will help you down the road. All right, let's see how we did. So a mixture of things. So the correct answer is actually thrombosis of the veins in the spermatic cord. So most of us would think that it's damaging the artery that causes testicular atrophy after inguinal hernia surgery, but it's actually thrombosis of those fine veins. And usually that's as a result of aggressive dissection of the hernia sac, especially if it's a larger sac along the way. And so you cause some essentially venous outflow obstruction, and that can lead to atrophy. The testicular artery is usually pretty identifiable, and it's most often seen and able to be preserved. Relatively rare, about 0.5% of people in primary hernia repair. That can jump upwards to about 5% in redo hernia repairs, but it's usually thrombosis of those small veins along the spermatic cord. All right, next question. You're performing an open ventral hernia repair and are selecting the piece of mesh to use in the repair. Which of the following answers correctly pairs the type of mesh with a property of that mesh? A, polypropylene mesh, it becomes incorporated into native tissue. B, polytetrafluoroethylene or PTFE mesh promotes tissue ingrowth. C, Vicryl or polyglycolic acid mesh is a non-absorbable prosthetic mesh. D, biologic mesh is contraindicated for use in contaminated fields. And E, microporous heavyweight synthetic mesh has a high rate of bacterial clearance. This is actually one of those questions I think there could be 2 correct answers on, and we'll kind of talk through them after you guys answer along the way. All right. So let's see how we did. So that is correct. So A is what we want to say. That's 57% of people got that right. So polypropylene mesh becomes incorporated into native tissue. And I think that's probably the most correct answer here. Let's talk through those couple other choices. So about 1/4 of you picked B, polytetrafluoroethylene or PTFE mesh. Gore-Tex is a lot of times it's called, the brand name is called dual mesh, if for those of you who are familiar with it. It was actually designed not to grow into tissue. It was kind of the first native anti-adhesive barrier that was used in laparoscopic ventral hernia repairs. I would say in general, most of us have moved away from kind of broad use of PTFE mesh because if it does get infected, it actually doesn't have good tissue ingrowth and is very hard to clean or clear out without removing the mesh. Vicryl is actually absorbable mesh. It's a rapidly absorbable mesh. So people use it for kind of temporary abdominal closures, but it usually goes away within a couple of weeks. The other one that I actually would have accepted is biologic mesh being contraindicated for use in contaminated fields. Technically, if you read the IFU or that little booklet that comes with all meshes, there is not any mesh that's actually indicated for contaminated field. Most surgeons historically have felt that biologic mesh was okay to use in contaminated fields because it ultimately goes away. But it certainly does not have an indication as the word kind of is listed. And then microporous heavyweight synthetic mesh have a high rate of bacterial clearance. Obviously, there's a lot of secondary factors that weigh into that, but in general, most of us feel that using a mid-weight and a macroporous mesh may be more amenable to bacterial clearance in the setting of infection. So a couple different answers there, but most of you got the correct answer of A. All right, next question. An 89-year-old woman presents with back pain and a reducible bulge on her back. What are the anatomic boundaries of the inferior lumbar or petit triangle? So there's 2 triangles in the back. This one's talking about the inferior lumbar triangle. I'll read the answers. A, 12th rib, latissimus dorsi muscle and iliac crest. B, 12th rib, the paraspinal muscle and the iliac crest. C, the 12th rib, the paraspinal muscle and the internal oblique muscle. D, external oblique muscle, latissimus dorsi muscle and iliac crest. Or E, 12th rib, external oblique muscle and latissimus dorsi. So a couple key things, not only do they use the kind of general name pedit, they also tell you it's the inferior lumbar, which usually means there's probably a superior lumbar when you think about it that way. And so use that information to help you kind of pick what the correct answer is. All right. So D is the correct answer. Broad range of things here. And again, this is just one of those things you have to know. I gave you some hints along the way. Some of you may have already answered it, but right. So inferior lumbar, we know that there's a superior lumbar hernia. That's called a Grinfeld-Leschäft defect. But I think the key thing here is superior one is going to have the 12th rib as the major border, whereas the inferior one is going to have your iliac crest. Again, you can see the inferior over on kind of right side of that diagram, the superior over on the left side of that diagram. So it's your iliac crest, your latissimus dorsi, and your external oblique muscle are the boundaries there. So some of this you just have to know, and some of it is kind of sorting it out along the way. You know, somebody who doesn't know a lot of things, you'd see the 12th rib was in, 4 out of the 5 answers. So that may be what you pick, but ultimately that's not where it is. All right, next question. A 58-year-old chronic alcoholic has an umbilical hernia and ascites of recent onset. He's never been treated with diuretics or salt restrictions. On examination, he has a massive amount of ascites with a large umbilical hernia with thin skin at the apex. You notice that there's a slow ooze of clear odorless fluid from the hernia. Therapy now should be A, umbilical hernia repair with prosthetic mesh, B, paracentesis and discharge, treatment with antibiotics and abdominal binder, C, trial a strict diuretic regimen and salt restrictions at home, D, hernia repair with placement of a peritoneal venous shunt, or E, bed rest, intravenous antibiotics, aggressive medical diuresis, and hernia repair during this admission. So I think as you guys are kind of answering here, the big key thing here that I think they want you to notice is he's never been treated with diuretics, and he's got drainage of fluid, right? So when we hear drainage of fluid in these things, that should always get you excited. All right, let's see what the right answer is. Good. So E is the correct answer. 70% of you got that right. And I think that's the key thing. Like, he's not toxic, right? But we do know that he's got a large amount of ascites. We need to treat the ascites first. Otherwise, the hernia is just going to come back. You wouldn't want to put prosthetic mesh in now. You don't want to discharge him because he's leaking ascites and you worry about SBP. So you admit him, you treat him with antibiotics, you diurese him down, and then you do the hernia repair during this admission to try and prevent further problems down the road. But I don't think if you don't address the ascites and his diuretic status, the hernia is just going to come back. All right, next question. After undergoing splenectomy for ITP, a patient has persistent disease concerning for missed accessory spleen, and a technetium scan is ordered to localize it. What is the most common location for an accessory spleen to be? A, in the small bowel mesentery, B, tail of the pancreas, C, the hilar region, D, the lesser sac, or E, along the diaphragm. Again, I think this is just one of those questions that you need to know. All right. So the correct answer is C, hilar region. Good. 2/3 of you got that right. So that's the most likely place that you'll see it. You can see on this nice little graphic kind of all the different places where they can present. The greater omentum is probably the second most common one after the hilar region. And then you can see them in the gastrosplenic ligament, splenorenal ligament, the tail of the pancreas, and even down in the pelvis. But most likely, if you're going back to look for a missed accessory spleen, would be in the hilar region of the primary spleen. All right, next question. Which of the following statements is true regarding overwhelming post-splenectomy sepsis? A, the mortality rate of post-splenectomy sepsis is between 50 and 60% in most series. B, the indication for splenectomy is not a factor in predicting the incidence of post-splenectomy sepsis. C, the risk of post-splenectomy septic episodes is essentially the same throughout life. And D, the risk of post-splenectomy sepsis is unrelated to age.
Let's say post-splenectomy sepsis 5 times fast.
I had to force myself to slow down. I'm going to make my kids do that on the way home.
Yeah, it's a good one.
No more seashells for them. We're moving
That's right.
on. Sepsis.
That's right. Tongue twister.
All right, let's see how we did. So the correct answer is A, great. So 3/4 of you got that right. The mortality rate of post-splenectomy sepsis is significant, 50 to 60% in most series. I think that when you look at these other ones, most people agree that as far as age, younger and older tend to be the most high risk. It does kind of depend on why you're getting a splenectomy. Obviously, elective splenectomy, we like to give the vaccines ahead of time. So that can help reduce some of the risk down the road. And then there is some variation throughout your lifespan. So good job for everybody. All right, we got 6 more questions we'll try to get through here in the next kind of 10 minutes along the way. Which of the following statements regarding preoperative splenic artery embolization is correct? A, splenic artery embolization is most useful before open splenectomy and adds little benefit to laparoscopic splenectomy. B, microspheres or gelatin powder are used to embolize the splenic artery. C, the pancreatia magna must be embolized to ensure complete splenic artery embolization. D, successful splenic artery embolization results in about 80% of splenic parenchymal becoming ischemic or splenic parenchymal. E, the goal of preoperative splenic artery embolization is to facilitate easier identification of the splenic artery intraoperatively. All right, let's see how we did. So D is the correct answer. Good. That was what the majority of people got. B, I actually think is a pretty good answer along the way. I don't do a lot of embolization, but one of the things I remember during training that we used to talk a lot about is if you put metallic coils in for embolization, it can actually make it kind of hard to staple across. So there is some consideration of using like non-coil things along the way, but ultimately the correct answer here is D. Successful splenic artery embolization results in about 80% of splenic parenchymal becoming ischemic. All right, next question. A 25-year-old, 220 kilogram female presents to the emergency department with 3 hours of acute onset right lower quadrant abdominal pain. She describes the pain as mild and reports persistent nausea and vomiting. There's moderate diffuse tenderness on exam. Her laboratory studies reveal a white blood cell count of 17,000 and a negative urine HCG. She unfortunately is too heavy to fit on your CT table. So which of the following diagnostic tests would be most helpful in finding the cause of the patient's abdominal pain? A, an abdominal plain film. B, abdominal ultrasound. C, DPL or diagnostic peritoneal lavage. E, diagnostic laparoscopy. D, diagnostic laparoscopy, or E, none of the above. This unfortunately is a more common scenario that we're running into, not necessarily at 220 kilos, but even in larger patients where we actually cannot get CT scans, or even some patients that don't fit in the CT scanner just because of the diameter limitations. So what are you going to do next? What would be most helpful? All right, let's see what we got. Good. So diagnostic laparoscopy is the correct answer. I think that's most useful. I don't think an abdominal ultrasound is necessarily wrong, although I think one thing you have to keep in mind when patients are this obese, the value of an ultrasound for evaluating intra-abdominal contents can be really limited just to the overlying subcutaneous fatty tissue. So the correct answer here to really figure out what's going on is a diagnostic laparoscopy. A 15-year-old boy presents to the emergency department with right lower quadrant pain, fevers, and a CT scan demonstrating evidence of perforated appendicitis with a 3-centimeter associated abscess. The mother would like to know, you relay the following plan to the patient's mother: admit, place on IV antibiotics, and have an interventional radiology place a drain in the associated abscess. The mother would like to know the risks and benefits of delayed operative intervention over just taking out his appendix during this admission. So what's the benefit of the delayed operative intervention? Higher intra-abdominal abscess rate, B, longer hospital stay, C, decreased postoperative complications, D, increased incidence of more extensive resection, or E, lower recurrence rate of appendicitis. All right, see how we did. So C is the correct answer. So about half of you picked that. The other majority of people picked option D. So increased incidence of more extensive resection. I would say that you're more likely to need a more extensive resection if you do immediate intervention as opposed to delayed intervention. You know, the benefit of delaying, letting everything cool down, let the abscess resolve, is you can hopefully reduce some of the inflammation and minimize the need for doing more of an ileocolic or a cecectomy. All right, we got 3 more questions. A 25-year-old woman presents to the emergency department with intense left lower quadrant abdominal pain and nausea. She says that the pain began several days ago as colicky pain. However, over the past several hours, the intensity has become more severe. She has vaginal bleeding currently and says that her last menstrual period was 6 weeks ago. Surgical history includes 2 C-sections and a tubal ligation. What is the most likely diagnosis? Ovarian torsion, diverticulitis, small bowel obstruction, appendicitis, or an ectopic pregnancy? Somebody asked in the previous question about longer hospital stay has been shown with interval appendectomy. Is this the reason this is wrong and the fact it's not a benefit? Yeah, I think they're trying to get at what's the benefit of doing it as an interval along the way. Correct. So the correct answer here is ectopic pregnancy. That is the right answer. So a couple key things in that stem that they want you to get at. She's a 25-year-old female. She's of the right age. Usually in females who present with vaginal bleeding and abdominal pain are the 2 most likely things you'll see in a patient with an ectopic pregnancy. So 76% of patients will have vaginal bleeding, 66% of patients will have abdominal pain. So those are the 2 most likely symptoms they'll have, and they usually will present 6 to 8 weeks after their last menstrual period. I think the other key thing here is that she's had a tubal ligation along the way. We know that that's a risk factor or an increased risk factor for having an ectopic pregnancy. All right, so we'll try to power through these last 2 in the last couple minutes so we don't get too far behind. A 79-year-old man on warfarin for atrial fibrillation presents with a large ecchymotic abdominal mass that crosses the midline. Computed tomography also shows blood in the prevesicular space of Retzius. He's diagnosed with a rectus sheath hematoma. He's tachycardic and hypotensive and is only transiently responsive to fluid resuscitation. In addition to anticoagulation reversal and blood transfusion, what other intervention would you consider next? Angiography with therapeutic embolization, exploratory laparotomy with hematoma evacuation, admission for close observation and serial H&H, D, discharge home, or E, continued fluid resuscitation in the emergency room. I think there could be some debate on this one as well, but. All right, let's see how you did. Yeah, so I think that was kind of what I was expecting. And actually, if you look at, so a couple things about rectus sheath hematomas, there's kind of 3 grades of them. Small, grade 1 or type 1 is a small, doesn't cross the midline, is overall stable. Those are the patients you can usually admit for close observation. Grade 2 usually is isolated to the rectus muscle. You can sometimes see it cross the midline. But grade 3, which is what this one is, usually extends down into the space of Retzius or can even be intra-abdominal. A lot of times they'll have associated systemic symptoms of tachycardia and hypotension. I think depending on where you're at, you could make an argument for both A and B. I think if you're at an institution that has appropriate interventional radiology where you can do therapeutic embolization effectively and efficiently, I think that's fine. I think what they really want you to pick up here is they're tachycardic and hypotensive, only transiently responding to fluid resuscitation. And so being in the operating room is never a wrong answer along the way. All right, let's do our last question here real quick. A 65-year-old 100-kilogram patient in the intensive care unit intubated after being admitted with sepsis. He's received a large volume of intravenous fluid resuscitation, and his intra-abdominal pressure as measured via the bladder is 18 millimeters of mercury. He has normal urine output and normal peak airway pressures. Of the following options, which describes the most appropriate management of this patient? A, continue current management as 18 millimeters of mercury is a normal intra-abdominal pressure. B, paralyze the patient. C, reduce fluid administration and minimize enteral feeding. D, insert an intra-abdominal drain. Or E, decompressive laparotomy as 18 millimeters of mercury is indicative of grade 3 hypertension. While you guys are looking at that one, somebody asked about the previous question, doesn't it depend on the quality of the skin as well as whether it's compromised or not? Yeah, I certainly think that's a variable to take into consideration in real life, not something that was mentioned in the STEM, but yes, if there's overlying skin changes and stuff, you know, a percutaneous or an interventional radiology wouldn't necessarily decompress that amount of fluid, whereas with an exploratory laparotomy, you can get all that hematoma out as well, or at least a good portion of it. All right, last question. We'll see how everybody did. So the correct answer here is C. So you kind of see a whole spectrum of things. You know, technically 18 millimeters of mercury is elevated. If you look at this table here, that would be what kind of people consider grade 2 intra-abdominal hypertension. I don't think there's anything wrong with paralyzing the patient, but in this situation, they tell you his urine output's normal and his airway pressures are normal. So there's really no reason that you need to paralyze the patient at this point in time. I think reducing fluid administration, minimizing enteral feeding is correct. There's no need for decompressive laparotomy at this time, as again, they have normal urine output and normal airway pressures. So I think just kind of knowing where you are along the spectrum and taking those key things that the patient's still stable shows you that you just, for right now, you only need to reduce your fluid administration, minimize enteral feeding. Obviously, if they have a change in their hemodynamic status, that can certainly change the situation along the way. All right, team, good work, everybody.
All right, Dr. Blatnick, that was a whirlwind, but well done. Excellent review of abdominal wall, spleen, and general abdomen. Thank you so much for your expertise.
My pleasure. Thanks for having me.
Now I'd like to reintroduce another great colleague and friend, Dr. Amber Traugott. I had the pleasure of working with Dr. Traugott when she was a trainee here at WashU and has gone on to an illustrious career as a surgical educator at The Ohio State University in Ohio. Dr. Traugott is involved in the surgery clerkship. She's an associate residency director and I believe director of the pelvic floor program as well. And so a distinct pleasure to have just a bit of her time here tonight, where she's going to lead us through a conversation on colorectal and anal disease. Dr. Traugott, thank you so much for being here, and your slides are coming up here momentarily.
Thanks so much, Dr. Awad. And thanks so much for the invitation. I really do enjoy participating in this webinar every year. I'm going to be going over some questions related to colorectal and anorectal disease. So I'll kick it off with the first one here. A 50-year-old man underwent a laparoscopic assisted sigmoid resection for diverticulitis 5 years ago. He now presents with left lower quadrant pain and a leukocyte count of 18,000. His CT scan is consistent with sigmoid diverticulitis. The most likely reason for recurrence is A, young age, B, carcinoma, C, gender, D, laparoscopic approach, or E, colosigmoid anastomosis. Oops.
All right. Oops.
So good. I mean, the vast majority of you got this correct. And so it's just an important principle that you don't want to leave sigmoid behind because the risk of recurrence is higher if you make a colosigmoid anastomosis as opposed to a colorectal anastomosis. All right, the next is in a patient with an obstructing cancer of the rectosigmoid and pneumoperitoneum, which of the following is true? A, the sigmoid colon is the most likely site of perforation if the ileocecal valve is competent. B, the cecum is the most likely site of perforation if the ileocecal valve is incompetent. C, the cecum is the most likely site of perforation if the ileocecal valve is competent. D, the transverse colon is the most likely site of perforation if the ileocecal valve is incompetent. And E, the transverse colon is the most likely site of perforation if the ileocecal valve is competent. So really, this is about understanding the interaction of the anatomy of the colon and the competency of the ileocecal valve when assessing where someone's likely to be perforated when they're obstructed distally. All right, C, so good. Again, almost everyone got this one correct. So the cecum is the most likely site of perforation if the ileocecal valve is competent. So with an incompetent ileocecal valve, the small bowel is able to dilate, and the patient can sometimes be decompressed proximally with a nasogastric tube. You know, the cecum is very thin-walled and has the widest diameter, and so is the most likely site to perforate, especially if that back pressure can't go through the ileocecal valve. All right, what are typical endoscopic findings in severe to fulminant chronic ulcerative colitis? A, mucosal sloughing. B, rectal sparing. C, colonic disease worse than rectal disease. D, skip lesions. Or E, patchy inflammation. So let's see what you all answered. So good. Okay, so the majority of you answered mucosal sloughing, which is the correct answer. C was the next most frequently selected answer, and the reason that that's not correct is that in ulcerative colitis, generally speaking, the disease is worse the more distal that you go. So you want to remember that usually the rectum will be the worst site of disease in typical ulcerative colitis, whereas you know, you may see patchy inflammation or skip lesions or more severe colonic disease than rectal disease. That's more consistent with Crohn's disease. All right, so next question, compared with postoperative chemotherapy and radiation therapy, preoperative chemotherapy and radiation therapy for treatment of rectal cancer may be associated with lower rates of A, overall survival for patients with T3 lesions, B, intraoperative blood loss, C, postoperative wound infection, D, anastomotic dehiscence, or E, abdominoperineal resection. All right, so most of you got this correct also. Abdominoperineal resection is the correct answer. And the reason for this is that when patients undergo neoadjuvant chemoradiation, And now, of course, we also see the more frequent employment of total neoadjuvant therapy, where they may receive a course of chemotherapy in addition to chemoradiation. You'll often see significant downstaging of those tumors, and that may take someone who could not have a sphincter sparing operation on presentation, and they may then be eligible to have a sphincter sparing operation when that tumor shrinks. They don't get the benefit of that if they get post-operative chemoradiation, although the oncologic outcomes are similar if they receive that preoperatively versus post-operatively. Okay, so the most common oncogene abnormality observed in association with colorectal cancer is which of the following? A, overexpression of the N-MYC oncogene. B, suppression of the ERB-B oncogene. C, amplification of the KRAS oncogene. D, amplification of the L-MYC oncogene. And I will just say that on standardized tests, they love to ask about the genetics of colorectal cancer and hereditary colorectal cancer syndromes. So this is something that you want to make sure that you take a look at before any standardized test, not just the ABSITE. Okay, good. Almost everyone got this. It's amplification of the KRAS oncogene. So good. You either know it or you don't. Okay. The next one is a 65-year-old man has mucus discharge and perianal discomfort. Physical exam reveals a fistulous opening lateral to the anus. Endoscopic exam allows passage of a probe through the fistula tract. The fistula traverses the internal anal sphincter, the intersphincteric plane, and a portion of the external anal sphincter. The fistula is categorized as which type? A, transsphincteric, B, extrasphincteric, C, intersphincteric, and D, suprasphincteric. All right, so correct. So most of you got this, just transsphincteric. So this diagram may be a little bit helpful for those of you who chose other answers. You want to kind of have this image in your mind when you're considering the anatomy of a fistula is where does this tract go relative to the internal and external sphincters as well as to the levators. And really, in this case, it's traversing the internal sphincter, the intersphincteric groove, and the external sphincter, making it an a transsphincteric fistula, which would correspond to C on this diagram. But certainly, this is a diagram you also want to review because fistula anatomy is also a frequently tested topic. A 65-year-old female with no family history of colon cancer presents to your clinic following a right hemicolectomy for stage 3 colon cancer. Her pathology results reveal a poorly differentiated tumor with signet ring components. What is the most likely molecular marker associated with her tumor? A, SMAD4, B, DCC, C, MSI, D, P53, or E, KRAS. Okay, so here we have a lot more heterogeneity in your answers, but the correct answer is MSI or MSI high status. And really, there are some characteristics that that tend to be associated with MSI, which is due to mismatch repair protein mutations typically. So those tend to be right-sided tumors. They often have mucinous or signet ring histology associated with them. It's frequently tested, mismatch repair proteins that cause microsatellite instability as a cause for Lynch syndrome as a hereditary colon cancer syndrome. So you also want to make sure that you know those genes that are associated with it and have some understanding about how we test for Lynch syndrome, both in specimens and in germline genetic testing. All right, a 55-year-old woman is referred to you for bleeding hemorrhoids. Proctoscopic examination reveals a brownish, non-ulcerated polypoid lesion, 1.5 centimeters in diameter in the anal canal, 2 centimeters above the dentate line. Intrarectal ultrasound examination shows the depth of invasion into the submucosa and no enlargement of perirectal lymph nodes. Neither side of the groin has lymphadenopathy. The patient has good anal continence. Biopsy shows melanoma. Which of the following is true? A, the anal canal is the most common site of melanoma. B, the treatment of choice is wide, full thickness local excision. C, preoperative chemoradiation therapy followed by wide local excision is the best treatment. Or D, another option for treatment is immunotherapy. Okay, good. So the correct answer is B, and about half of you chose this answer. The treatment of choice is wide, full thickness, local excision. So this is a relatively early stage anal canal melanoma. And so the prognosis for this patient would be similar with both with local excision and with APR. So we would not typically recommend an APR for this patient, although that wasn't a choice given to you here. But in this case, the patient doesn't have, deeper invasion beyond the submucosa, and they don't have evidence of lymph node metastasis. So you would try to get a full thickness local excision first, and then see how the patient did after that. Certainly immunotherapy can be used in the treatment of melanoma, but generally speaking, it's going to be more effective in a patient that has more advanced disease than this. 52-year-old man without symptoms is undergoing screening sigmoidoscopy. A 2-centimeter yellow submucosal nodule is found in the rectum 6 centimeters from the anal verge. Findings at deep endoscopic biopsy suggest carcinoid. Appropriate management includes which of the following? A, observation. B, chemoradiation. C, transanal excision. D, low anterior resection. Or E, abdominal perineal resection. So let's see what options you chose. So good. So the majority of you chose transanal excision, which is the correct answer. The second most common answer was low anterior resection. So let's talk about that a little bit. So, you won't always be given the histology with this description. And it's important to kind of have a differential in your mind of what submucosal rectal tumors are likely to be. Carcinoid is one of the most likely, but GIST is also likely. And so you want to kind of review what's appropriate management for those tumors because it is different than adenocarcinoma. And so in this case, you would obtain a transanal excision because you really just want to get a negative margin on a carcinoid. They're not the same. They're not the same level of aggressiveness, and so are not treated the same way. You may get a scenario on a standardized test where they give you a description of a tumor like this and may give you other signs or symptoms that might indicate that the patient might have liver metastases or may take you down a diagnostic road. And so you want to kind of review the evaluation of a suspected carcinoid in addition to just the management of it. All right, 2 years after a sigmoid colectomy for a stage 3, so T3N1M0 carcinoma of the colon, a 55-year-old man has a solitary 2 centimeter in diameter metastasis in the periphery of the right lobe of the liver. The most appropriate management is A, right hepatic lobectomy, B, wedge resection of the lesion, C, external beam radiation therapy, D, ligation of the right hepatic artery, E, infusion of 5-fluorouracil via the hepatic artery. So good. The answer is B, wedge resection of the lesion. A few of you also answered right hepatic lobectomy. An anatomic resection is not required for a small peripheral metachronous liver metastasis after prior colon cancer. And that would be a pretty morbid operation relative to the size of this lesion. All right, next question. A pedunculated polyp found incidentally at colonoscopy is removed by means of snare polypectomy from the ascending colon. Invasive cancer to the level of the submucosa is identified histologically within the polyp. The lesion is well differentiated. No lymphatic or vascular invasion is found. The cauterized margin does not contain neoplasia. Appropriate subsequent management includes which of the following? A, right hemicolectomy, B, subtotal colectomy, C, endoscopy in 6 months, D, repeat endoscopy with fulguration of the polypectomy site. And most of you said endoscopy in 6 months, but I'm not surprised that the next most common answer was a right hemicolectomy. So let's go to the next slide and we'll go over that. So management of a polyp with cancer in it, malignant polyp, is really a very frequently tested question. And so I've put this table up as kind of a summary of risk factors for residual or recurrent disease after polypectomy or for lymph node metastasis, which would be reasons why you might consider doing a right hemicolectomy in this case, if any of those factors was present. So in this case, this was a snare polypectomy, not a piecemeal. It was a well-differentiated tumor. It involved a submucosa, but it's a T1 lesion with a negative cauterized margin. So negative margin is 1 to 2 millimeters, depending on the study you look at. But generally speaking, they're not going to give you an answer in that range. And doesn't have perineural or lymphovascular invasion. If all of those are present, it is a low risk polyp, and you can do endoscopic surveillance for that. But if you have any of the things in the right column, then that's a high-risk polyp for either having residual disease at the polypectomy site and or for having lymph node metastasis. And so in that case, you would want to do a formal right hemicolectomy and make sure that you did a high ligation to make sure that you got adequate nodes for staging. Okay, which of the following is most predictive of perforated appendicitis? A, younger age. B, white blood cell count greater than 10,000. C, tenderness at McBurney's point. D, female sex. Or E, more than 3 comorbid conditions. And I think risk factors like these are important to know because you'll often be given them in the context of a more clinical scenario. And you'll want to know, which patients might be more at risk because they may choose such a risk factor to kind of highlight a management point in a more clinically oriented question. So in this case, E is the correct answer, more than 3 comorbid conditions. And given kind of the distribution of answers, I would say, that there's a little uncertainty about those risk factors. Keep in mind that patients with multiple comorbidities often do not present with a traditional septic picture early. Okay, they may be on steroids, they may be obese, they may have a more delayed presentation, or they may have other factors that could mask an appendicitis until it becomes perforated, and they may present later. So it's important to consider that. Generally speaking, younger patients are not necessarily at higher risk. And that seemed to be the most common second answer after E. A 20-year-old man visits your office because he has had anal pain during and after bowel movements for more than 2 months. There's also bright red blood on wiping. There's no problem with diarrhea or abdominal cramps. Examination of the anal canal reveals a 5 millimeter by 5 millimeter deep anal fissure in the posterior midline of the anus. Which of the following statements is true? A, the unhealed fissure is caused by repeated trauma from bowel movements. B, lateral sphincterotomy is effective but can result in decreased continence to stool. C, the triad of anal fissure consists of fissure, sentinel skin tag, and internal hemorrhoid. D, nitroglycerin paste, not past, increases anal resting pressure. Okay, so the correct answer is B, lateral sphincterotomy is effective. It is probably the most effective treatment we have for fissure, but can result in decreased continence to stool. Now, we tend to do this in modern times by doing a partial sphincterotomy rather than a complete sphincterotomy. And back when they first started doing it, they were more generous with their incision, and I think incontinence was a more common complication when it was performed in that way. The unhealed fissure is not caused by repeated trauma from bowel movements, although certainly if someone has hard stools that can interfere with healing, but really fissure healing is impaired by decreased blood flow caused by sphincter spasm, which is why our treatments all focus on ways to relieve that, whether that's with topical smooth muscle relaxants or with interventions directly on the sphincter. A number of people also posted in the Q&A about the previous question about younger age with perforated appendicitis. And I think that the question maybe was more in the context of adults, but you raise a good point. Yes, young children who can't communicate may also have an increased risk of presenting with perforation because they are also may present later. So so I think that you bring up a good point. But outside of the pediatric population, young adults are not at an increased risk.
All right, and our last question in this section.
A 60-year-old male with hypertension and coronary artery disease underwent open aortic aneurysm repair. On postoperative day 2, the patient develops abdominal pain and diarrhea. He has a temperature of 38.4 Celsius, his heart rate is 110, and his blood pressure is 100/60. On examination, he has diffuse abdominal tenderness and distension. A flex sig is performed, and this demonstrates gray appearing mucosa. What's the next step in management? A, intravenous fluids and antibiotics. B, a colonoscopy to visualize the proximal colon. C, CT scan. D, exploratory laparotomy with resection and colostomy. Or E, exploratory laparotomy with resection and primary anastomosis. Okay, so good. The correct answer is D, exploratory laparotomy with resection and colostomy. So the important points here are that you should recognize the patient has ischemic colitis secondary, most likely to inferior mesenteric artery occlusion due to the AAA repair. You also want to recognize that the description is telling you that the patient has necrosis. And so if the patient had less striking findings on flex sig, and didn't have frank necrosis, you could make an argument for watching the patient and treating them with antibiotics if they had mild ischemia. But this question is designed for you to recognize that the patient has necrosis and you need to intervene surgically early. You don't want to make an anastomosis in this setting, but very few of you selected that option. Well, I think that's my last question. Thank you so much for inviting me.
Dr. Agate, thank you again. Phenomenal overview, and really appreciate your wisdom and being with us tonight. Always a pleasure. Thank you again. And then for our final panelist on our part 1 ABSITE review is really a pleasure to have every year Dr. Timothy Reland. Dr. Reland is a general surgery in San Antonio, works at Brooke Army Medical Center. He's a general surgeon by training and specializes in HPB and surgical oncology. Dr. Reland did his medical school, I believe, in St. Louis, if I'm not mistaken, Tim. So if you're ever missing toasted ravioli or Emo's pizza, we'll send some along.
Yeah, I'm from St. Louis, so I miss that all the time, but I know not everybody feels that way.
It's an acquired taste, I guess.
Yes.
But, well, Tim, thank you again so much for being here. Dr. Reland is going to lead us in the discussion of small intestine, biliary disease, and flexible endoscopy, and your slides are coming up here shortly.
Great. All right, well, thanks for sticking with us until the last 30 minutes here. We'll try to move through the questions and give you as many pearls as I can. So first question, which of the following statements is true concerning postoperative ileus? The presence of peritonitis at the time of original operation will delay the return of normal bowel function. Contrast radiographic studies have no role in differentiating early postoperative bowel obstruction from normal ileus. The routine use of Reglan hastens the return of small intestine motor activity. Or D, the use of IV pain-controlled anesthesia or PCA has no effect on return of small bowel motor activity. Hopefully this is fairly straightforward. All right, how do we do? Good. Most people got A. So yeah, I mean, a patient that presents with peritonitis, they have a higher risk of ileus. That sort of makes sense. You know, the contrast radiographic study, I think it does help differentiate those when you see, diffuse dilation and contrast sort of slowly moving through, then you know it's an ileus versus any sort of real obstruction. The C I thought was funny because I use Reglan all the time in any upper GI case that I do, but there's no data to support it. So that's what that's getting at there. And then PCI obviously slows down GI function. So I think that one fairly straightforward. Patients who present with peritonitis, perforated bowel, whatever it may be, they're going to have a higher risk of ileus. All right, on to the next. If a bile duct injury is suspected at laparoscopic cholecystectomy, appropriate management includes which of the following? Laparoscopic attempted repair is the preferred option. Postoperative external drainage should be avoided. Ducts greater than 4 to 6 millimeters in size seen at cholangiography can usually be ligated without consequence. And Roux-en-Y hepatico-jejunostomy is the preferred procedure in most cases. I think, again, not a whole lot to this one. Hopefully most people got this one correct. All right, so correct answer, Roux-en-Y hepatico-J is a preferred option in most cases. Most people, interesting. So option A, a lot of people said laparoscopic attempted repair is preferred option. I just, I think if you use common sense there and think about what most people are going to do in this situation, they're going to open. I think if you have a common duct injury, the right answer in most surgeons' minds is that you should open and do it sort of the easiest way that's possible. And D is most people, most of the time, if you have a real injury, you're going to do a Roux-en-Y hepatico-J. I think part of what that's getting at is that hepatico-duodeноstomy is sort of the old school option, but we don't use that very often because there's this problem where it's called sump syndrome, where you get little food particles getting into the bile duct, and you get cholangitis, and you can get cirrhosis from that long term. So a defunctionalized jejunal limb Roux-en-Y hepatico-jejunostomy is the preferred procedure in almost every case for common bile duct injury, or if you have to reconstruct the common bile duct. I don't think we're at laparoscopic being the preferred option yet, maybe in 30 or 40 years. But all right, next one. Which of the features present on abdominal ultrasound is most suggestive of acute acalculous cholecystitis? Hypoechoic fluid surrounding the gallbladder and highly echogenic stones within the gallbladder. B, gallbladder wall thickening with increased vascularity and large hyperechoic structure at the neck of the gallbladder. C, positive sonographic Murphy sign, a thin gallbladder wall and sludge within the gallbladder. Or D, gallbladder wall thickening and hypoechoic fluid surrounding the gallbladder. So acalculous is obviously a key part to this question. And then what do we find on acute cholecystitis? I think that kind of the two things you got to know here. All right, so correct answer, gallbladder wall thickening, hypoechoic fluid, and no mention of stones. So I think, the other ones you go through, obviously what they're referring to with the highly echogenic stones and the hyperechoic structure at the neck of the gallbladder is acute calculous cholecystitis. And then thin gallbladder wall and sludge would still be calculous cholecystitis. So in order to be acalculous, you can't see stones. So that's why D is correct. All right, next one. 44-year-old woman has obstructive jaundice caused by a mid-bile duct stricture 4 months after a laparoscopic cholecystectomy. Which of the following statements is true for this patient? Surgical reconstruction offers a better chance for long-term success than either percutaneous or endoscopic dilation. Both endoscopic or percutaneous balloon dilation can be completed in a single operative session. C, the success rate at 5 years following surgical reconstruction approaches 50%. Surgical reconstruction is the only option for treatment of this patient. This one, I think, if you don't overthink it, you'll get it. But I do think there are a couple where you can convince yourself that it's true. So the correct answer is A, which most people got. So surgical reconstruction offers a better chance of long-term success than either percutaneous or endoscopic dilation. So I think, in order to know that's true, you have to think, why did they get a bile duct stricture, right? And it's generally ischemia. It's some sort of mild thermal injury or something like that during the surgery. And then it's not a real injury to the duct. It's an ischemic insult. And so over time, the duct narrows. And so, yeah, you can dilate that up, but it's not going to work long term. So the best chance for long-term success is going to be surgical reconstruction. So I thought B, I know a lot of people answered B. B I thought was tough because I guess you could do that in a single operative session. It's not typical, right? I mean, you're typically going to either do the endoscopic or the percutaneous dilation. You could sort of do both within one trip to the operating room. So I do think that one was a little tricky, but A is absolutely the answer. So, understanding the timing of a bile duct stricture can help you on a few questions. So an early stricture is always ischemia. A late stricture, you should think of malignancy first, probably. So you're going to want to do brushings and things like that. But a stricture within 6 months of a lap chole, it's ischemia. The only way to fix it really permanently is to do the surgical repair. Again, a defunctionalized hepatico-jejunostomy. All right, next one. 45-year-old male with a history of previous right hemicolectomy for colon cancer has colicky abdominal pain that has become constant over the past few hours. He has marked abdominal distension and has had only minimal vomiting of feculent material. His abdomen is diffusely tender. A radiograph of the abdomen shows multiple air fluid levels with dilation of some loops to greater than 3 centimeters in diameter. The most likely diagnosis is A, a distal small bowel obstruction, B, a closed loop small bowel obstruction, C, a proximal small bowel obstruction, or D, acute appendicitis. So you got to try to think of what distinguishes those different small bowel obstructions, unless you want to go with acute appendicitis. All right, so the correct answer is A, distal small bowel obstruction. I think the key there is feculent vomiting, right? So B for closed loop, typically those patients will have bilious vomiting because it's almost always the proximal closed off part of the closed loop is going to be very proximal, right? So you won't have feculent material coming back all the way from the distal small bowel because there's, it's not connected because of the closed loop. So I think the feculent vomiting is the key there, that it's going to be a distal small bowel obstruction. I think it would be difficult to differentiate based on the information given between a closed loop and a proximal. A closed loop, one of the telltale signs can be that the stomach is not very dilated on your imaging. The small bowel is dilated, but the gastric bubble is small because they vomit up what little bit they have in there. And then the rest of the small bowel is just dilating with that closed loop, and the fluid is not refluxing all the way back to the stomach. So, but they didn't give you that in this case. The key here is feculent vomiting. I did think that minimal vomiting can be tricky because that almost makes me think closed loop. So if I ever see a patient with a CT and they have all this dilated small bowel, but they haven't been vomiting much and their stomach bubble is not big, I look very closely for a closed loop in those cases. But again, feculent giveaway distal small bowel. All right, 80-year-old female returns to the emergency department on postoperative day 5 after laparoscopic feeding jejunostomy tube placement. Her feeding tube fell out at the nursing facility roughly 2 hours ago. What is your first course of action? A, obtain an upright abdominal exam. B, take the patient to the operating room for emergent tube replacement. C, consult IR for tube replacement under fluoroscopic guidance. D, attempt to replace the Gi Endoscopy tube at the bedside. E, admit the patient to the hospital with a plan for elective tube replacement in the operating room the following day. I think some of this is gamesmanship, how to take the test, general surgery exam.
Mhm.
All right, so correct answer, attempt to replace the Gi Endoscopy tube at the bedside. So this one, very controversial, kind of across the board. We got some different answers. So I think let's go through each of them. A, I think probably people thinking for A is what's your first course of action. It's not crazy to get an upright abdominal exam, but I think when you're answering a question, if you can evaluate and treat the patient, it's kind of like that a bunch of people ask about that colorectal question. Well, wouldn't you give antibiotics first? Yes, but we all know that when they ask the question about the AAA, they want you to do a surgery with an ostomy, right? To resect and do an ostomy. So you just got to kind of play the game here. So they want, you're the surgeon, you're going to attempt to replace it. It's also been a very short time. They don't give you any information about tachycardia or peritonitis. I think if you add that information in the stem, then you go to the operating room. But they don't give you that, so don't assume it. It's only been 2 hours. You can probably slip the tube back in, so you would try that. I would do it with a C-arm, fluoro, or some kind of X-ray, squirt some contrast, etc. And then if that failed and they still had normal vital signs, weren't peritonitic, you might have IR try it with fluoro. And then, after that, you're probably going to take them to the operating room. E is definitely wrong. You can't do that electively. All right, 15 minutes. Let's move on to the next one. All right, which of the following is a risk factor for bile duct carcinoma? A, cigarette smoking. B, Crohn's disease. C, estrogen administration. D, PSC or primary sclerosing cholangitis. And E, ingestion of nitrite-rich foods. This one I think is, you sort of know it or you don't. Not a whole lot of logic you can use to get to this one. So PSC, primary sclerosing cholangitis, most people got this one. Again, I think it's sort of, most people just know this one. I guess you could use the fact that it's chronic cholangitis that causes bile duct cancer. Cigarette smoking, interestingly, probably increases your risk somewhat because it causes increased risk of basically every cancer. Crohn's disease, small bowel adenocarcinoma is probably the one that you'd be tested on. Estrogen is going to be breast and endometrial, and then nitrite-rich foods is gastric cancer. So PSC absolutely linked to the risk of cholangiocarcinoma or bile duct cancer. Someone asked, don't we want a mature tract before attempting? Yeah, absolutely, you want that. But if the patient comes in, 4 or 5 days after, you give it a whirl, and if it doesn't go easily or you don't feel like it's going well, then I would abort that bedside try, but it's worth a shot. All right, 68-year-old male has abdominal pain, distension, nausea, and vomiting 6 days after a lap chole. On physical exam, he is afebrile, mildly tachycardic, and has moderate distension and tenderness without rebound. Lab values show an elevated white count at 11,000, total bilirubin of 3.4, alk phos of 119. Next step in the patient's diagnosis should be A, ERCP, B, HIDA-scan, C, exploratory laparotomy, D, ultrasound, or E, percutaneous hepatic cholangiogram. This is also a common board scenario, so have your algorithm ready. All right, so first step is going to be a radiocarbon ultrasound, and the things you'll look for on that. One, you want to see, is there a clear fluid collection? So it's a bile leak, and the bile ducts are usually not dilated with that. Or you'll see minimal fluid, just post-operative fluid, but you'll see dilated intrahepatic ducts. So ultrasound is cheap. It's easy to get in the ER. It doesn't require all this other stuff. It'll give you some answers right away. And then typically, if you see dilated ducts, you're going to get some sort of imaging, either a CT or an MRI, to try to evaluate how far those ducts are dilated down. And that helps you make your decision between ERCP and PTC, because ERCP is not going to work well if there's a clear clip across the common duct and there's no visualized duct down below that clip, because you won't be able to get a wire across. So then you might just go straight to PTC. Otherwise, ERCP generally is a good option because they might be able to stent across something and stop things from leaking. Yeah, so my algorithm would always be ultrasound first, then cross-sectional imaging, HIDA scan with a patient with a bilirubin of 3.4, unless they have a leak on the ultrasound, then you might get a HIDA scan. But usually if it's a clear transection of the duct, you're going to get cross-sectional imaging and then drain one way or the other. The other key thing that comes up quite a bit is 72 hours is kind of the magic mark here. So if you're clearly within 72 hours, the patient's stable, doesn't have any signs of early sepsis, then you can go fix it right away. If it's been 72 hours or they're tachycardic or anything that makes them look sick at all, you drain and delay for somewhere between 6 weeks and 3 months. So that's when you're going to do your PTC typically and drains. All right. What is the most common form of intrahepatic iatrogenic injury from dissection in the dissection bed during laparoscopic cholecystectomy? A, inadvertent injury to the liver during ductal dissection. B, mistaking the common duct, the common bile duct for the cystic duct. C, mistaking a replaced right hepatic artery for the cystic artery. D, thermal injury in the duodenum during dissection. E, mistaking a right hepatic duct that arises from the cystic duct as a true cystic duct. One is maybe a little tricky too, but the most common iatrogenic injury is going to be mistaking the common bile duct for the cystic duct. So dissecting below the line of safety, dissecting on the wrong side of the common duct. So you can find videos of this on YouTube. They're terrifying. But if you start your dissection too far over, you mobilize the whole common duct, thinking that that's just the cystic duct. You don't completely clear your hepatocystic triangle. You don't get a critical view. And then people clip right across the common duct thinking it's the cystic duct. So the other common answer here people gave was A. I think A is the tricky one. I guess I would say it's not a real injury. Yes, you very often burn the liver a little bit during ductal dissection or during a gallbladder. But if you do that during ductal dissection, you are probably in a very bad place, right? To get to the liver and not hurt the common duct would actually be sort of difficult to do during ductal dissection specifically. So if it's an inadvertent injury to the liver, taking the gallbladder off the cystic plate, that would be very common, but that's not a real injury most of the time anyway. And I think do we have the picture of the Strasberg? Yeah, Strasberg classification. So I don't know that you need to memorize these for the ABSITE, but have an idea. So, these are kind of duct ablutia or cystic duct leaks. These are typically managed with sphincterotomy, and they usually shut down. Sometimes you have to put a drain in the fluid collection. This aberrant right, so a right posterior sectoral duct can often run right in the dissection area. And so that can be injured frequently. Now, a lot of times these may not be noticed. So if it's a small duct, what will happen is just your right posterior sector will atrophy. And in a patient who hasn't had their bile duct instrumented or anything, they won't actually get cholangitis. If you injure this in a patient like with a hepatic OJ or who's had a sphincterotomy and they get some bacteria in their bile duct, they'll typically get cholangitis from those bile ducts getting dilated and blocked up. But you may just have a patient whose right posterior sector atrophies over time and the rest of their liver hypertrophies and nobody ever knows. And then D is a injury to the duct, but not a complete transection. And then all the E types are complete transection of the common duct. And so these are the ones that are typically fixed with a hepatic OJ. All right. 35-year-old female presents with acute onset of left-sided abdominal pain after 2 days after jogging for 2 hours. She is hemodynamically stable. She undergoes a CT scan of the abdomen with IV contrast, which reveals a moderate amount of hemoperitoneum and a splenic artery aneurysm that is ruptured. After initial stabilization, she undergoes angiographic coil embolization of the aneurysm. Which of the following is true regarding splenic artery aneurysms? Splenic artery aneurysms account for approximately 20% of all splenic aneurysms. They are often associated with a higher mortality in a non-pregnant woman. Treatment should be offered for all aneurysms greater than 3 centimeters in diameter or aneurysms in a pregnant woman. They affect men and women equally, or E, none of the above. All right. So the right answer is treatment should be offered for all aneurysms over 3 centimeters. So any really any splenic aneurysm of that size and any aneurysm that's identified in a pregnant woman, those should all be treated. They for A, it's more than 20%, and the rest of them were fairly straightforward. Definitely affect women more often, and the higher mortality is in pregnant women. No, not all aneurysms, all splenic aneurysms. So splenic artery, common hepatic artery, those are the ones that are typical. 20-year-old woman with jaundice has a fusiform dilation of her extrahepatic bile duct. Therapy for this condition is aimed at prevention of which of the following complications? A, choledocholithiasis, B, sclerosing cholangitis, C, cirrhosis of the liver, D, duodenal obstruction, or E, carcinoma of the bile duct. So kind of 2-level question here. What's the diagnosis and why are we treating it? All right, so carcinoma of the bile duct, so this is a type 1 choledochal cyst, and the thought is that there's refluxing pancreatic juice into the bile duct that can cause cancer. So you should have some vague idea of the types and how you treat them. Type 1, you just resect the duct that's dilated and do, again, defunctionalized hepatocyte. That's come up on 3 questions. All right. Next question. Sorry, I'm running out of time. I'm gonna run over. Which of the following has been shown to reduce the risk of postoperative ileus? A, early TPN. B, limited IV fluid during the perioperative period. C, stopping patient-controlled anesthesia postoperative day 3. D, NG decompression for at least 2 days post-op. E, the use of LR for postoperative fluid replacement. All right, so the correct answer is limited IV fluid in the perioperative period. We had some people answer C, stopping PCA on postoperative day 3. Yeah, I mean, I think early stopping is probably associated with that. How you define early, I wouldn't necessarily use day 3. But I think limited IV fluid is absolutely shown to decrease ileus. NG decompression has not. Most people go away from NG tubes now. For things that, for straightforward bowel surgery. The other ones are clearly wrong. All right, 61-year-old female who underwent laparoscopic cholecystectomy for symptomatic cholelithiasis. Pathology shows a 5-millimeter poorly differentiated gallbladder adenocarcinoma invading into the perimuscular connective tissue. There is no invasion into the liver or serosa. LVI and perineural invasion are present. The cystic duct margin and cystic duct node are both negative for malignancy. Staging shows no metastasis. CA19-9 is 253. What would be the next best step for this patient? I actually thought this one was a little tricky as well. We'll see.
Dr. Reland, are you still there? Oh, I think we might have lost him. All right. Well, on that note, answer D is the correct answer. Segment 4B5 resection with portal lymphadenectomy for this level of invasion. They're basically saying, oh, yeah, we lost him, that there is no invasion into the liver or serosa. And so answer D, the kind of extended hepatectomy is not indicated in this case. That's really kind of the main differentiating factor there. All right. Well, I'm sorry we lost him, but we do want to thank Dr. Vreeland for participating in the session there. His clock may have run out on his Zoom account, but a tremendous whirlwind review of part one of our app site today. I think it's joining us back here. Tim, thanks. We lost you for a minute there, but I was just thanking you and the other panelists, no problem, for contributing your time and expertise in helping out our audience today with part one of our app site review. Really, really tremendous review on a broad array of topics. Just in a couple of closing remarks. One, again, we sincerely thank you all for being here and being a part of the SAGE's annual general surgery and app site review session. We'll have part two coming up next month. I do also want to just remind folks about a tremendous opportunity to join SAGE's and to be a part of the next annual meeting in Montreal. Check your passports, make sure they're up to date, and then you can go. Again, SAGE's candidate members have tremendous steep discounts on registration, membership, and other opportunities. In the next session, we're going to reconvene in January after the holidays, and we'll go through part two, which will include a gambit of other general surgery topics. In the meantime, I do wish everybody a safe and happy holiday season. Please do look out for a poll or survey afterwards that will ask you about today's session. We take your feedback very, very seriously and work towards improving it for a future session. So thank you again, everybody. Have a safe evening and Happy New Year. We'll see you in 2023. Good night.